Yeah, thank you. Just a moment. Thank you, Dr. Kim, for your very, very nice introduction for us. And we're very glad we can join again with our webinar. So I want to introduce this first speaker. Is Dr. Olarik, is our friends from Thailand. He is Dr. Olarik is work in the Chopaya Abe Hospital. Sorry, my pronunciation is not so good for Thailand spelling. His area of interest is reproductive medicine, gynecology endoscopy, clinical research epidemiology, and health technology startup. And since 2016 until now, he was his social media team of American Society of Gynecology Laparoscopy. And 2018 until now, he's assistant director for lecturer and research affair of Medical Education Center. And 2019 until now, he's a chairman of Subcommittee Continuing Professional Development, the RoyalThai College of Obstetricians and Gynecologists. And 2019 until now, also, he's a Subcommittee of Reproductive Medicine and Subcommittee Gynecology Endoscopy, the RoyalThai College of Obstetricians and Gynecology. So it's time to you, Dr. Olarik, for your presentation, please.
Thank you, Chairman and Co-Chairman. Thank you for having me here. Good evening in Thailand time and maybe good afternoon in Europe, right? Good afternoon in Nigeria. We have our friend from Nigeria and South Africa. Okay, I would like to share my slide. Let me check. Okay, can you see my slide?
Yes. Yeah.
Okay. Okay. So today I will talk about the adenomyosis, tip of the iceberg in infertility. Okay, and this is my hospital. Can you see my hospital?
Ooh, looks like a palace.
Yes. It's like it's an old palace. It's 110 years old already. Professor Hugo already visit our hospital. Okay. Okay, so and please feel free to contact me via the WeChat because I know today we have a lot of the audience from China. You can save my presentation also. Okay, and for the disclaimer, I don't have anything to disclaim. Okay, the outline today is I will talk only two topics. Okay, evidence-based of adenomyosis and infertility. And the second one is experience-based of adenomyosis and infertility because Professor Lee, he's talked to me that we want to like a panel discussion. We want to know about the experience, not only the lecture. Okay. So what about the evidence-based of adenomyosis and infertility? I think all of us know the type of the endometriosis. Now we have 4 types of the endometriosis. The first one is a peritoneal endometriosis that the lesion is on the peritoneal cavity. The second one is endometrioma. It means the endometriosis at the ovary. Even one side or both sides is endometrioma. The third one, and I think this is very difficult for the surgeon, I mean for the gynecologic laparoscopy to do is deep endometriosis. The definition is not really clear, but some literature said deep endometriosis is endometriosis lesion is deeper than 5 millimeters. And the fourth one is this. Is this a nightmare of the infertility treatment? It is the adenomyosis. Okay, so how it happened? This is the good picture for the theory of the endometriosis. The first one is very famous. It is Samson theory. It is a retrograde reflux of an implantation of the endometriosis tissue. Okay. The second one is early embryonic development of the lesion. And the third one is in situ metaplasia development. Why we have three theory? Because now we know that only one theory cannot explain how the endometriosis is occur. And this is the endometriosis. I will show the theory of the adenomyosis. Because now we know that maybe adenomyosis have the different pathophysiology of the endometriosis. This is the literature from my good friend Sylvia. He published about 2 years ago. It is about the theory of the pathophysiology of adenomyosis. Is it the invasion of the endometrium to the myometrium tissue? And there is a tissue injury and repair. Repeat and repeat and repeat. Okay. After that, there is some proliferation and fibrosis. And also there is abnormal sexual receptor. We know that in endometriosis, there is increase of estrogen receptor, and there is a downregulate of progesterone receptor. And there is also the inflammation of the tissue, and there is a new neuroangiogenesis. That's why the lesion can grow by itself. And this is the another good theory. Now we have a theory about the adenomyosis. The first one is invagination from the endometrium to myometrium. This is the first one. The second one is that there is a stem cell in myometrium, and there is a new growth, or we call the de novo, in myometrium tissue. And the third one is invagination from the outside. Professor Chapon showed the data that there is a correlation between DIE and endometrial and adenomyosis, because the DIE will infiltrate from the outside to the posterior wall of the myometrium or the uterus. And he showed the data that show there is invagination from the bladder endometriosis to the anterior wall of the uterus. By the way, we know that only one theory that cannot explain. So why we have the three theory? Okay, and how we diagnose the adenomyosis. And now we don't have the clear statement how to diagnose the adenomyosis. Only the histology after we do the hysterectomy. But how about the imaging? There are a lot of the school want to describe how to diagnose the adenomyosis. But I think this is very good one and very easy to understand. We call that this is MUSA, morphological uterus sonographic assessment. We have a RoyalThai type that we can looking by the ultrasound. The first one is line and birth. The second one is echogenic Iceland. The third one is the cyst. And after that, if the disease is progressed, we can see the irregular of the junctional zone. We can find the fine shape of shadowing. Someone said it's like a moose head, something like that. And the indirect side is a globular shape of the uterus and asymmetrical thickness of the uterine wall. Okay. And this is, I think, is very, very important that we need to know and we need to do. It is about how we describe the adenomyosis or how to report the adenomyosis, because the location of the adenomyosis, the size of the adenomyosis is affect to the infertility treatment. I think it's same as the myoma. Now we have the physical classification of the myomas 8 type. We have to describe type 1, type 0, type 2, because the location, the size is effect on infertility. And now this I show you this type of the adenomyosis. The location, focal or deep field, is it a cystic or is a layer extend the size? This is very important. Okay, so we know that adenomyosis and endometriosis associated pain. The woman will have the dysmenorrhea, dyschezia, and also dyspareunia. Dyspareunia is very, very important, but because if the woman have the dyspareunia, she can not have sex. So if she don't have sex, how to have the baby? Okay, so this is very, very important. And how the endometriosis and adenomyosis affect the infertility. There is some data. Let's talk about the sex and endometriosis. There's the data nearly 50% suffer from painful sex if they have the endometriosis. Okay, and this is the pathophysiology and of the endometriosis. It's effect of the uterus. It's affect uterus. It affect peritoneum cavity and also the ovary. I don't have time to tell you the detail how it affect the infertility, but I think you can discuss after this. Okay, this is why endometrioma affect the infertility. There is a very, very special molecule study how it affect. Okay, it's not only about the infertility, but its effect on the reproductive outcome. There's the data show the increased rate of spontaneous miscarriage in endometriosis, and also have the adverse effect on the preeclampsia, on the placenta malposition. You can see most of the outcome is statistically significant. Spontaneous abortion, PIS, I mean the preeclampsia, gestational hypertension, chronic hypertension, GDM, fetal malpresentation, and also the preterm delivery. And some studies say that there is an effect on the ESGE, small for gestational age. And how we manage the adenomyosis. This is the basic treatment. The first one is expectant. The second one is medical treatment. I mean, we can use the GnRH agonist, we can use the progestin, we can use the aromatase inhibitor. I will tell you after this. We have the surgery, radical surgery, conservative surgery. That's sure for in our field for the infertility treatment, we cannot do the radical surgery, except the lesion or the disease is very severe. We have to radical surgery and then go to use the surrogacy. And another treatment is uterine embolization. And I think Professor Aili, she will talk about the HIFU. Okay. What is the role of the medical treatment in management of adenomyosis? We have a lot of the data that the medication is very, very effective treatment for the adenomyosis, for pain, for abnormal uterine bleeding, but not for infertility treatment. Okay, this table is very clear to show that the mechanism of the action of the GnRH agonist, when you inject to the patient, she will go to the hypoestrogenic state. So that's why the disease is improved. The progestin, we have a lot of type. The progestin, we can use the MPA, we can use the dianogest that can treat pain. Abnormal uterine bleeding is very good, but not for infertility treatment. LNGIUS, we use the levonorgestrel IUD put inside the uterus. And after that, there is no bleeding or the bleeding is decreased. But we know that it is a contraception, right? And COC, the mechanism is a decellulite and a subsequent atrophy of the endometrium. And we know that it is a contraception pill. Okay, the NSAID is very good for the pain, but there's some data that the NSAID, when you give to the patient, there is no ovulation, there's no rupture of the oocyte. So most of the medical treatment that not give the benefit for the infertility treatment, except a GNIS agonist, we have a lot of the data that for the long protocol, we give GNIS agonist before the treatment of the IVF. Okay, sometimes there's a pregnancy rate is increased, but we need more data. Okay, so how about my experience based on the adenomyosis and infertility? And for this year, I am the chairman of the ASIM SIMSIC. What is the SIMSIC? SIMSIC is a complementary and integrative medicine special interest group. That means I use everything for my patient to get pregnant. This is the definition from the USA about integrative health. What is the integrative health? Is a conventional plus complementary approach to make the patient better. Holistic approach, patient focus, wellness, mental, emotional, functional, spiritual, social, and community aspect. We look for the whole person. Because of infertility, we treat the patient. We not treat only the disease. Most of the infertile couple, they have a psychological problem. They suffer that they cannot have the baby. And now they suffer, they have the disease like adenomyosis, endometriosis. The woman have a pain, have a dyspareunia. So we have to look for the whole person, not only the adenomyosis. This is my experience. Even the patient cannot preg by herself. They can use the surrogacy. We not treat the adenomyosis, but we treat the infertility for them. Okay, this is the option. So the most important thing I think is infertility treatment care plan. This is my picture during the COVID-19. Now in Thailand, we don't have a new case for almost 2 years. Most of the new case, they're from abroad and stay in the state quarantine. This is a new normal. I have to wear the eyeglass. I have to wear the mask all the time. I have to use the telemedicine to talk to the patient. Okay, and sometimes I use the PPE to do the operation. Okay, in my experience, when I treat the adenomyosis and infertility, most of my patients, they have combined. It's not solely adenomyosis, but mostly combined with endometriosis and pelvic adhesion. So I do a lot of the laparoscope. And this is the robotic acid machine in my hospital. So I'm a solo surgeon. My nurse, she can sit outside the operation room to wait for my operation. You can see this is a voice control. It's very good, and my nurse love it. Okay, and this is okay. This is my diagram when I see the patient who have the adenomyosis and endometrioma. Mostly, I do the operation because my patient have a pain, my patient have a dyschezia, so I do the operation. After that, I will allow them to natural pregnancy or do the IUI. But after our plan, if not success by the natural or the IUI, I will send the patient to do the IVF. Okay, this is my diagram. And thank you. So we have more time to discuss, and please feel free to contact me personally. You can save my WeChat. Okay, thank you.